We have some amazing keynotes this year, and the first of which is System Transformation to Address the Opioid Crisis. Chethan Bachireddy is going to be here. I'll tell you a little bit about him if you're not familiar with his background. Dr. Bachireddy is the Senior Vice President and Chief Health Officer for Harris Health System. He's currently leading the system's efforts to improve outcomes and reduce inequities among the county's most vulnerable residents. In particular, his work focuses on applying evidence-based practices and accelerating health equity through transformative partnerships with academic, business, community, and government entities. So I'm delighted to introduce him. One thing I want to remind you about at this meeting is all of us are here, particularly our folks at universities, under the auspices of academic freedom. I'm speaking in many of the ways that I talk and share my conversations as a private citizen of Texas, not the views of my university, and we support that in everything that we do. So I'm delighted to introduce Dr. Bachireddy. Thank you so much.
I think this is for me. Well, first of all, good morning, everyone. Thank you so much for being here. Can you guys hear me okay? I realize I'm mic'd up, and this is actually not a mic. This is just a light. But I'm going to do my best to speak into it. And so, it's a real honor to be here, a real privilege. Been thinking a lot about this and, wondering, who's going to be here? What are the messages? What are the things that we need to learn together? And one of the first things that came up is, the thing that I think binds us all together is both this recognition of the importance of people's lives and the lives that we've lost. And I think the other thing that binds us together is the really hope we have that we can do something about it. And so over the next few minutes, I'll be talking about just that topic. How might we transform systems to start to address the overdose crisis? And so I think I should be able to change my slides. And that's how you do it. So this presentation, it's supported, you see that there, by the TTOR, Texas Targeted Opioid Response. None of the views here are official. They're only my views. So don't reflect federal, state, local government, any organization I've worked with in the past, currently, or in the future. This is my financial disclosure. I own stocks in the following healthcare-related companies. 3 of them are immunotherapeutics for oncology, and 1 is AI in healthcare. The learning objectives are 4. The first is to understand, explain the evolving overdose crisis. It has changed. The second is to identify updates to clinical practice and where that clinical practice differs from the evidence. The third is to recognize Medicaid's role in expanding access to addiction care. And the fourth is to examine innovative care models for the most vulnerable. So I want to tell you about Jane. So Jane is someone I met in Virginia. She had overdosed once, twice, 3 times. And each time she overdosed, she stopped breathing. In some cases, she almost entirely lost her pulse. She was found down by EMS, brought into the emergency department, given the opioid antagonist naloxone, and brought back. And what a way to be brought back. Each time she was brought back, she experienced painful withdrawals, something that I know many folks here are intimately familiar with. And for those symptoms, for her opioid use disorder, for her near brush with death, she's given Imodium, ibuprofen, and clonidine. She's given a ham sandwich, sometimes a turkey sandwich, in our emergency department, a warm blanket in the wintertime, and discharged to the street because she's homeless. And within an hour, within a few minutes, she can be found preparing a cocktail of heroin, often adulterated with fentanyl or other substances. And what's remarkable about this is that she hates it. She hates every single moment of this experience. And really she wants treatment, but she doesn't know where to go or how to get it. There are 2.5 million Americans who have an opioid use disorder. In 2021, this chart here shows the rapid increase in overdose deaths in our country. 106,000 individuals died from an overdose death in 2021. And that number, according to provisional data from the CDC in 2022 and 2023, it's not getting better. It's starting to plateau, but it's certainly not getting better. In terms of lives, what that means here is that by the end of my presentation, 15 Americans will have died. By the end of this conference, we're looking at 300 a day, almost 600 Americans will have died. Those are profound numbers at the end of this conference. This is only a 2-day conference, and yet we're seeing really steep rises in overdose deaths. That holds true for Texas as well. We heard earlier from our representative that 6,000 Texans have died, and you saw a similarly steep rise from 2019 to 2021 in terms of overdose deaths. COVID-19 was clearly an inflection point in the overdose crisis. From 2019 to 2020, you saw almost 30% rise in overdose deaths that were particularly acute, particularly steep among certain racial and ethnic minority groups, Alaska Native, American Indian, and Black. You also see that among non-Hispanic white and Hispanic members and individuals as well. It's clear that COVID-19 definitively worsened our overdose crisis. In addition to the social isolation, the psychological distress, and economic challenge of COVID-19, we also saw a real change in our drug supply. And what this figure shows, and I realize it's really, really small, is essentially which substances were involved in drug overdose deaths across our country, again, from 1999 to 2021. And the most important point is that really small gray line that you see there, which is synthetic opioids. Think fentanyl. And you see that skyrocketing starting around 2015, and similarly, you see that for psychostimulants and cocaine. Psychostimulants is the yellow, and orange is cocaine. Even I'm having a tough time seeing it. And so, I think the thing to recognize here is that the steep increase in overdose deaths has everything to do with the real change in our drug supply. So we are experiencing a different type of crisis than we've experienced in the past. And so we have medications for opioid use disorder that have been demonstrated to reduce the risk of overdose death. 30, 40, 50, 60, 75%, depending on the population. And so the question is, are we using them? Are we using these medications that can save lives? The short answer is no, not really. According to the National Survey of Drug Use and Health, again in 2021, of those with an opioid use disorder, just 22% received any medication for opioid use disorder. And by medication for opioid use disorder, I mean buprenorphine, methadone, and naltrexone. And within this group of individuals receiving it, Black adults were less likely to receive MOUD. Even when individuals started MOUD, many did not remain in treatment for very long. In a national study over the course of about 15 years, looking at the duration of buprenorphine treatment across the country, they found that just 26% of buprenorphine episodes, buprenorphine treatment episodes, were longer than 6 months. Just 26%, right? And so if you multiply those together, you get a really tiny fraction of individuals who are starting to benefit in the ways they could and should from life-saving, evidence-based medications. Retention on MOUD is critical. It's critical, and we know this from study after study after study. Persistence, and by that I mean consistent and continuous adherence to medications, receipt of medications, and duration of opioid agonist therapy, and by that I mean methadone and buprenorphine, has been consistently proven to reduce drug use, improve quality of life, reduce emergency care, reduce death. These are all the things we care about. And so, of course, retention and duration is a key metric. It's so important that our National Quality Forum, which is the standard bearer of all things clinical quality in the country, states that a minimum duration on MOUD of at least 180 days, 6 months, is really what we should be aiming for, at the very least, when we talk about quality in opioid and care for those with opioid use disorder. And the research, real-world research among low-income individuals, those in the Medicaid program, show that you start to accrue benefits in terms of reductions in overdose risk as early as just 2 months on MOUD. And that continues to increase month over month, at least up until 12 months, if not longer. So the longer you're on MOUD, the better you do. And so that really puts into context the numbers that I showed earlier, the 22% and the 26%. We are falling short. So what are we supposed to do with that, right? How do we move forward? How might we start to align what we know with what we do, clinical practice with evidence, so that we can better treat individuals with opioid use disorder, we can start treatment, we can retain individuals in care, really provide a low threshold, high retention approach to care. Over the next 5 slides, I'm gonna touch on a few areas, I thought this was important, where the prevailing dogma and practice at times is at odds with the evidence. And of course, this is not everyone. This is really reflective of just my experience as a trainee and as an early clinician, seeing where there was a real difference between the way we practiced and the way we cared and what the evidence showed us. And so the first area, the first myth, is around buprenorphine dosing. And so I learned as a trainee, as I was coming up, was that we were supposed to minimize daily buprenorphine dose. The lower the better. The lower the better. And if you keep it low, that's better for the patient. It's better for them. And what I've learned by looking at the evidence in my own clinical practice, and there's a wonderful citation there that no one can see, by Grande et al. In 2023 in the Journal of Addiction Medicine, that reviews the literature and convincingly demonstrates that there's a dose-dependent benefit for buprenorphine. But it's not dose-dependent downwards, it's dose-dependent upwards. And so there are benefits in terms of reduced drug use and improved retention in care, the higher the dose of buprenorphine, up to 32 milligrams. And it may be higher, it just simply hasn't been tested above that. And so my sense, and this is where, this is my clinical judgment, is that particularly in the era of fentanyl, patients should, for the most part, be on 16 milligrams per day or higher. And that's something all of us can take a look at, is where are some of our biases and where is our clinical practice and how does it align with the evidence that we see. The second is around recurrent drug use, what many of us know or have learned of as relapse during buprenorphine treatment. I was taught or picked up along the way that, patients who experience a recurrence of substance use while they're on buprenorphine, that means they failed. And in some cases, it meant that they were kicked out of treatment. It couldn't be farther from the truth. Those who experience recurrence should be provided additional resources and support, changing the formulation of buprenorphine from a tab or a film to a long-acting injectable, connecting that patient with a peer, that person with a peer, making sure that they have housing, safe and supportive housing, rather than cessation of life-saving medication. The third is around counseling. And there was a similar story here where traditional counseling was thought to be absolutely necessary for buprenorphine treatment. And so there are some programs that I've come across that kick people out if they don't engage in counseling on a regular clip or cadence. At the end of the day, our treatment recommendations, our practice should be about care, about caring the person for the person in front of us. They should be person-centered, developed with and according to someone's circumstances and their goals. Traditional counseling is not necessary for successful outcomes in buprenorphine treatment. That doesn't mean it's not important. It just shouldn't be grounds for really stopping buprenorphine treatment. And that's a really fine distinction, but an important one to make. The fourth is around withdrawal management for opioid use disorder. And this is a policy that's in place quite a bit all over the country, which is that withdrawal management is largely thought to be the effective treatment for opioid use disorder. There's evidence to show, and I'll share a little bit later on in this presentation, that withdrawal management can actually increase the risk of overdose death. There are no data showing that withdrawal management is better or more effective than the gold standard of medications for opioid use disorder. And this is the last one, around prior authorization. And I didn't mention this before, but I was the former chief medical officer at Virginia Medicaid, so this one is near and dear to my heart, which is that it was thought that prior authorization was necessary to make sure that docs and patients were being judicious in prescribing appropriately. The evidence doesn't bear this out. Prior authorization, time and again, has been shown to reduce buprenorphine initiation and retention, the very two metrics that we're really falling short on. Diversion-related harms, right? A lot of this comes down to the threat or the fear of diversion. Diversion is rare. It does happen, yes, and it is rare. And when it does happen, guess what? People do better. So I'm not recommending diversion by any means, but it's important to really understand some of the choices we're making and the implications they have in context. And so then the question becomes, right, just, we know the evidence. We have a sense of what the science is, what good looks like. How can policy help us close that gap between what we know and what we do? How can it support the implementation of evidence-based care? This is where Medicaid has an enormous role to play in expanding access to high-quality, person-centered care. A huge, huge role to play. And part of that has to do with the mechanics of how Medicaid is set up. It is the largest payer in the country, larger than Medicare. It covers 25% of all Americans are in the Medicaid program. That includes Medicaid and CHIP, Children's Health Insurance Program. And of all those with opioid use disorder, it covers approximately 38%, right? So you start to see how state by state, where Medicaid is administered, Medicaid has an outsized role in really caring for and providing access to individuals with opioid use disorder. And as goes Medicaid, so goes the rest of the state and the payers, at least in my experience. Lack of insurance is a barrier to care. Everybody here knows this. Everybody here knows that lack of insurance is a barrier to care. And just to get into the numbers a little bit, 6 in 10 of those who are uninsured, they go without needed care. And that's not just for stigmatized conditions like addiction, which is probably higher. That's for all conditions. 6 in 10 go without needed care. So how can we start to address the overdose crisis using the tools at our disposal if people can't access care? And when it comes to particularly addiction, opioid use disorder, and buprenorphine, there's a recent study that demonstrated, looking at other health insurance plans and out-of-pocket expenses, that a $1 increase in daily increase in out-of-pocket cost for buprenorphine, right, $30 a month, it decreases the odds of retention of about 12% for every dollar increase. So it has really tangible and specific implications for our ability to respond to the crisis. The chart you see in front of you, again, quite small. You should know that it's blue and orange. That's probably the most important part. And on the blue side, you see the blues are doing a little bit better, and the oranges are doing a little bit worse. And really what this chart shows is the percentage of uninsured adults, 19 to 64, in the United States. And on the far left is Massachusetts, a state where I've practiced, where 3.4% are uninsured. That's the best, right, in the country in terms of states. And on the far right, it gives me no pleasure to say this, but our state, my home state of Texas, is on the far right at 24%. 1 in 4 adults have more difficulty accessing care because they're uninsured. And the blue and the orange, yes, you guessed it, has to do with those who've chosen to expand Medicaid and not. And so, we face similar challenges in Virginia when I landed there as a chief medical officer. And so how did we address this? We did a couple of very specific and, dare I say, replicable things from 2017 to 2022. We focused on our Medicaid programs because that's where the folks with opioid use disorder and substance use disorder more broadly were. We extended coverage to the full continuum of addiction services. I'll talk more about that. We increased reimbursement on par with commercial rates. That's rare in the Medicaid program. We expanded coverage. We became the 32nd state to do so. We were extremely focused on removing barriers to MOUD, and you'll see that as well. And we thought differently about our patient population and understood that there were particularly moments of vulnerability where we had the opportunity and the responsibility to support individuals in a different way. So this is the chart I saw when I came to Virginia as the chief medical officer at the Medicaid program. Virginia was facing its own overdose crisis. From 2007 to 2017, drug overdose deaths had doubled, largely driven by opioids. We knew we had to do something. And so, again, Medicaid was the largest payer. But to be honest, our Medicaid program, we weren't ready. We weren't ready we didn't have the structures in place. Our addiction treatment landscape was fragmented, it was incomplete, and the experience of care for patients in the Medicaid program was pretty poor. Because of low rates, confusing billing, stigma, providers were wary to even enroll in the Medicaid program. And without addiction treatment providers, you have no access, even in the midst of this chart, even in the midst of the stories of people dying. People were reluctant to enter into the Medicaid program. So in 2017, we launched the ARTS program, the Addiction and Recovery Treatment Services Initiative, which transformed the landscape of addiction care, not just in Medicaid, but across the state. It extended coverage of addiction treatment beyond pregnant women to all Medicaid beneficiaries, reimbursed for the full continuum of care as sort of put out by the American Society of Addiction Medicine. So think inpatient, residential treatment, partial hospitalization, intensive outpatient, you get the point. We carved in addiction treatment services into the benefit for our beneficiaries. In a lot of places, it's actually separate, and it's really confusing for individuals who have Medicaid or really any insurance product. We increased reimbursement rates on par with commercial rates. And we introduced novel evidence-based models of care, including peer recovery supports, something that exists in Texas Medicaid today, and the office-based addiction treatment program. Our OBAT, Office-Based Addiction Treatment Program, was, and I think remains, an innovative program, in part because it pays extremely well. It pays extremely well for a program in Medicaid to support what we think is better care, what we think is the care that people with substance use disorders, really all of us, deserve: a longitudinal, team-based, interdisciplinary approach to care that's personalized, evidence-based, and trauma-informed. OBATs place the patient at the center. And again, that team, that interdisciplinary team, is working to meet not only their needs from a substance use perspective, but also their behavioral health needs, their medical needs, and their social needs. It consists of an addiction clinician, physician, a licensed behavioral health clinician, a nurse care coordinator, and a peer. And I put this here, and I hope these slides will go out, because again, the payment mattered. The payment mattered because it supported this type of care that, again, doesn't exist across the continuum of medicine, let alone in substance use. Really care that is designed around and for people, and for people with substance use disorder in particular. Actually, I'll just give you one sort of specific detail here. And so on the care coordination side, so it's $140 for induction. For care coordination, it's $243 per member per month. So if you had 100 members, Medicaid, that's what we call Medicaid beneficiaries, in your patient panel, that is approximately $300,000 that you're getting for the care coordination, for this interdisciplinary approach, for addressing their medical, their mental health, their addiction, and their social needs. In 2019, Virginia became the 32nd state to expand Medicaid. And overnight, we doubled the number of individuals with substance use disorder who had access to care. And as a practicing clinician in Virginia, practicing in a specialty outpatient in an OBAT, I saw the change. I saw the change overnight. It went from people who would come to me, patients maybe after they were homeless, maybe they came after an overdose in the emergency department. They were able to access care. I had confidence that they could go to the pharmacy and they would be able to fill the script that I gave them for buprenorphine or some other medication. I had confidence, for the most part, that they would come back. Our no-show rates went down and people did better. And you see this across the country. In the 40 states that have expanded Medicaid, you see time and time again that this particularly helps those who are most marginalized, who are most vulnerable. It particularly helps those with substance use disorders. After implementing the new addiction benefit, increasing reimbursement rates, expanding Medicaid, we went around the state to talk to clinicians and patients, FQHCs, health systems, to figure out what was working and what wasn't. And there was a lot that was working, yes, but there was a lot that wasn't either. And so as we started to learn about these opportunities, we went to work operationalizing them. And I'm including a few here that I think were most relevant. One is we immediately removed the prior authorization for buprenorphine. We removed what's called a lock-in program for buprenorphine in particular. We removed the copays. Nominal copays even can be a barrier for those who are extremely poor for receiving their medication at a pharmacy. We allowed 90-day prescription and dispensing of buprenorphine and naltrexone, and that took actually changing the state regulations, not only Medicaid policy. We held over 230 trainings to start to provide the evidence to our network of providers and really share our expectations and standards. We mandated access to MOUD at every step of the continuum. And I'll just say the difference that made in particular was really stark. So when we made that change, we were finding just 27% of our patients who went through residential treatment were accessing MOUD. Overnight, when we mandated it, one, our residential treatment provider list got smaller. But the second thing that changed is the number of individuals who are accessing MOUD almost doubled to 54% when we made that change. And so really demanding a higher standard of care, right? It's not that 100% of people will get MOUD, but that is available and accessible and is understood and recognized as the gold standard is extremely important. We doubled reimbursement for peers, and we really encouraged integration of physical and behavioral health. With these changes collectively, we saw a huge increase, an enormous increase in addiction treatment providers from 2016 to 2022. And I'll just, 486% increase in addiction treatment providers in a relatively short period of time. Like I said, our addiction treatment prior to these changes was quite anemic. And so it was really, it made such a huge difference. New providers came to our state. Different providers who only took commercial insurance started to accept Medicaid. And they started to change their practice as well to provide better care for all of our patients. We went from no inpatient treatment coverage to 70, for residential treatment to 94. We increased OTPs accepting Medicaid by 600%. And overall, this made such a profound difference for our patients. They were finally able to access care. And what this meant in terms of MOUD was that 592% increase in individuals receiving MOUD on an annual basis. From 6,000, again, that's really tiny, from 6,000 in 2016 to 9,000 in 2017 when the arts program was started. That continued to increase in 2018 to 12,000. And with Medicaid expansion almost overnight, the number of individuals accessing MOUD doubled to 24,000 and continued to increase during COVID-19 to 43,000 today. So we went from 6,000 individuals accessing MOUD to 43,000 individuals. 6,000 to 43,000 within a few years based on these specific policy changes. All right, we'll take that. And the first thing, thank you for that. And the first thing I'll say is that there was unbelievable support from the Medicaid program, from our leaders to do this work, from clinicians on the ground. And so, I'm lucky to be able to present it today, but there are thousands of people who made this possible in the state of Virginia. And maybe I'll just say one more thing here, and we'll transition a bit. That if it's possible in Virginia, there's nothing, people in Virginia will say there's something special about Virginia, but I'll say there's nothing so unique or different about Virginia that this can't be done across the country, and it has been done in some places, right? I'm just naming one story, but there are so many other stories across the country, even here in this great state that I bet some of you in this room have, about what's possible when we're focused, what's possible when we start to center people, and what's possible when we're willing to collaborate and iterate together. And so, the story here is not over, because I think one thing I want to make sure that I share is that payment innovation is important. Absolutely, payment innovation is important. It's necessary, but it is not sufficient. It has to be paired. It has to be twinned with delivery innovation. Quite simply, overdose death discriminates. Those at greatest risk are the most marginalized. People who are incarcerated, people who are homeless, those with serious mental illness. They have much higher rates of overdose deaths than than individuals with opioid use disorder who don't have those. So even there's a spectrum, there's a continuum of individuals with opioid use disorder, and the risk changes over time, and it differs across populations. Our models of care, they're not designed to accommodate for this fluctuation and change of risk. They're not designed to accommodate those who are most marginalized. In a landmark study from Marc LaRochelle et al. From Boston Medical Center, they identified all opioid overdose deaths in Massachusetts, and they looked 12 months back. They just looked 12 months back, and they asked the question, well, what happened? Were there opportunities? Could we have done something differently? And what they found is of all those who died from an opioid overdose, 19% experienced opioid detoxification, withdrawal management, 19%. 17% had a non-fatal opioid overdose, presenting to EMS or the emergency department. 9% had been released from incarceration, and 6% had been hospitalized for an injection-related infection. There are many lessons you can take from here, but I'll just share a few. The first is, again, that the risk changes over time. So for example, someone who's incarcerated within 2 weeks of release has a much higher risk of death than someone who's 12 months out. The second is that there are ways to predict who is most likely to overdose. And if there are ways to predict who's most likely to overdose, then there are multiple opportunities to engage individuals in different types of care. The emergency department represents one of those rich opportunities, those ideal opportunities to predict overdose death and to prevent it. In a follow-up study, these same authors followed for, again, 12 months, individuals who had a non-fatal opioid overdose. They said, what happened to these folks? Did they access care? And what they found, unfortunately, was that, the same story, no, not really. About 30% accessed any MOUD in the 12 months after their non-fatal opioid overdose. And within that, there was some nuance. Those who received naltrexone didn't experience a mortality benefit. However, those who received buprenorphine and methadone did. They had a 60+% reduction in overdose death compared to those who didn't access any MOUD. Buprenorphine initiation during acute care, right, in the ED, in the hospital, makes a big difference in terms of increasing engagement and linkage to outpatient care. And I'll name 2 RCTs that really drive this home. The first was at Yale, where they randomized individuals to start buprenorphine, right? Start MOUD in the emergency department. And what they found was that single act alone doubled engagement rates at 30 days compared to referral. In another RCT conducted at Boston Medical Center again, the authors found that initiating buprenorphine among hospitalized patients was 6 times more effective than the standard of care, withdrawal management or detoxification, in terms of engaging patients in care at 180 days. When we came upon these data, when we came upon these care models, we knew that our standard of care wasn't going to cut it. In the state of Virginia and across the country, roughly 8 to 11% of individuals were engaged in MOUD at 30 days after an ED visit, after a moment of crisis, after they had been identified as being at particularly high risk for overdose death. This makes the case for a bridge clinic. At its core, a bridge clinic is about offering same-day initiation of medications for opioid use disorder in the hospital or in the emergency department, followed by stabilization and linkage to community-based care. Let's walk through what it looks like for a person presenting to the emergency department. So someone comes to the emergency department, they're identified as having an opioid use disorder, they're initiated there and then on buprenorphine, a peer meets them at the bedside, talks to them, engages with them, forms a type of therapeutic alliance in that really critical moment of crisis, schedules a follow-up appointment within 24 to 72 hours after discharge, gives them their number, calls them to make sure that they got their medication after discharge, if they have any challenges with accessing care in making that immediate appointment. And then the very next day, a bridge clinic clinician and peer meets that same person and patient and engages them in care. When we started this work in Virginia, there were only 3 bridge clinics across the state. Understanding the importance of this particular moment when someone who's vulnerable presents to the ED, we invested in a number of strategies to start to ensure linkage to care upon discharge. We introduced reimbursement for buprenorphine initiation in the ED. We created a process where our managed care organization, right, the insurance companies who administer Medicaid, they'd receive ADT feeds, which are real-time feeds about whether someone has been in the emergency center. And we asked that they reach out on the same day to individuals who had just been to the emergency department and make sure that they had access to everything they needed. And we funded the expansion of bridge clinics from 3 to 15 and encouraged telehealth and peer recovery specialists as a core component of this program. And within a few years, we saw a real change in the number of individuals who were accessing MOUD at 30 days after an emergency department visit. We started 11% in 2017. We went to 27% in 2019 and to 37% in 2021. I hope what you take away from this case study, from this experience, from this example, is that it's necessary and possible to design specific models of care for those who are most vulnerable in an evidence-based manner and in a way that is person-centered. Know that 37% isn't good enough. We have a lot more to do in Virginia and certainly around the country. But before we wrap up, I'm going to see who's been paying attention. And so this quiz, right? You guys are going to have a quiz. This is a pop quiz, right? Because I didn't tell you ahead of time. So this is definitely a pop quiz. This will be partially anonymous. And so what I mean by partially is that, you know, one of the great things about the Hova app is that it actually will list your names next to your final score. But don't worry, no social security number, no addresses, no phone numbers, no other identifying details. And so we'll get to it. And so what I'd ask you to do, if you can, is go into your app, your Hova app. In your app, click on the session you're in right now. And within there, I think it's polls, if I'm not mistaken. And I'm getting a thumbs up. So you click on polls, and you'll be able to answer the question, or try to answer the question. Of those who initiate buprenorphine, what percentage are retained beyond 6 months? Well, wait a second here. Actually, I don't know how I'm going to get feedback on this. I don't know. Oh, you'll make that. Thanks.
All right, we're getting strong responses to 26%.
Okay, very good. You guys have clearly been paying attention. The correct answer is 26%. Thank you. And that was the correct answer, Lucas Hill. I can tell in my app. It's been demonstrated that higher daily doses of buprenorphine lead to higher risk of overdose, lower retention in care, higher retention in care, or more ED visits.
We're at about 90% higher retention.
Okay, that's right. Very good. Nationally, what percentage of those with opioid use disorder are covered by the Medicaid program?
We're a little less certain here, but we're thinking 38.
38, okay, that's right. Very good. This is the second to last one. So La Rochelle et al., this same paper, found in Massachusetts in the year after a non-fatal opioid overdose, how many receiving any MOUD, and which of, were all the medications associated with decreased mortality, just one, just two, A, B, C, or D?
We've got some A's, but most of the audience and I myself are thinking it is B.
It is B. So it is B. 30% received any MOUD among this extraordinarily high-risk population. and only methadone and buprenorphine were associated with decreased mortality in this study. And this is the last one. From 2016 to 2022, the annual number of Virginia Medicaid members who received MOUD increased by ABCD.
Thinking it is a very impressive, nearly 600% increase.
Okay, that's right, that's right. So 600%, all right. I should be clapping for you guys. So, thanks. And so, we'll wrap up here, but I wanted to come back to Jane. I wanted to come back to Jane because Jane visited the emergency department a 4th time. Believe it or not, she visited a 4th time, but this time she didn't overdose. She came specifically asking for treatment. She said, I'm here for treatment. Can someone please help me out? And we were able to help her out. She was in luck. We had just started an ED bridge program, so we initiated buprenorphine right then and there in the emergency department. We scheduled a follow-up telehealth visit in 24 hours and then sent her home with enough medication to that appointment. And to the follow-up, I got to see her in clinic a week later, and she was unbelievably grateful to the team, to this process, and she had so much to be angry about and upset about. But she was so grateful for what we were able to do. And even within a week's time, it seemed as if, or this is what she shared, that her trajectory on life had changed within a week. I mean, it's hard to overstate these things. And I think what was really lucky for me was to be able to see that, was to see what a difference it makes when we start to care for people differently. I think the reason she was so hopeful is that we surprised her. She probably came to the ED not even expecting we'd be able to do anything, and we were. And within, we made sure that she was able to get in care literally the next day, followed up with her in person in a week, connected her with a care coordinator and a peer. And so, there are hundreds, there are many stories just like Jane's around the country. In that particular clinic, we were able to increase engagement as well by about 300%. And just in that one health system alone where I practice, VCU, we've treated and likely potentially saved the lives of hundreds of individuals. I think the point I want to make here around Jane is that change is possible. We don't have to accept the status quo. We don't have to accept thousands of deaths. That these deaths are avoidable if we're willing to demand better and design care around people. This is the conclusion. I think you all sufficiently have passed the test, so you don't need this so much. But I think the point that I'll end with and then look forward to the dialogue is that change is really hard. Change is really hard, and I know everyone in this room knows that intimately, knows that painfully, that change is hard. It's really, really hard. But we also know, and the other reason we're in this room, is that we know that change is necessary. 42% of Americans, and probably all of us here, know someone who's died from overdose. And we can change that. We can do something about it. And so my last sort of parting comment is that change is possible. Change is possible. And when I look around this room and when I see all of you, and I've gotten to meet a few of you already, I believe that. I believe that. And so I'm excited to learn from you, to partner with you, and just want to say thank you and look forward to the questions and the dialogue. Thanks.
Do you want to
Yeah.
start for questions? Okay.
Yeah, let's
So
do
we're going to take some questions from the audience. I guess I thought to get us started, I'm going to ask a selfish question. You pointed out relatively quickly the issue related to detoxification as a strategy.
Yeah.
And I was wondering if you could opine on that a little bit more, because it's an important piece. When I was training, that was a really standard thing, and we talked about it. And I would say for all of us in the audience, we spend a lot of time talking about detox beds and things like that. And I'd love to give you a chance to talk a little bit more about that and your thoughts.
Yeah, first of all, thank you, for that question. And what I shared with you, those 5 points, were things that I had to unlearn. And so I felt they were appropriate to share with this audience, and that maybe some of you know about the evidence, maybe some of you have been able to change your practice. I had to unlearn it, and see where we were inadvertently causing harm. Because all of us here, none of us want to cause harm. We want to do everything we can to care for individuals and to save lives. And so withdrawal management, inpatient detoxification is one of those sticky wickets, one of those challenges that remains with us. And I think probably the most convincing data point is when you start to look at, and again, this paper by La Rochelle et al. Really brought home to me and allowed me to articulate the challenges with it. I knew it in theory. I wasn't really able to quantify it enough to have a basis for starting to change practice and policy at a state level. And so understanding that those who went through inpatient detoxification, had I think it was a 60x increase in mortality, accounted for 19% of overdose deaths. Well, something's got to change. Something's got to change. And so we looked at our data, specifically in Virginia Medicaid, around residential treatment and inpatient detoxification, because we were paying for inpatient detoxification. And so we're like, wait, are we causing harm here? Are we really working at odds with our values, with everything we're trying to do? Are we paying for this? And the answer became clear and clear that the answer was yes, we were. And so we had to do something differently. And so what we ended up doing was taking the step to say, we're going to mandate at least access to MOUD at every level of care, from inpatient to residential, and et cetera. And as part of that process, we baked it, yes, there was prior authorization, we baked it into that prior authorization that there was a plan for, was someone offered it at least, and taught about the importance and the gold standard and the effect and the impact that MOUD can have. And is there a plan for continuing care upon release? It's important to, yes, offer it. Someone can say no. That's up to them to be able to do that. But that it's even accessible, that there is an understanding that can make a difference, we felt was really important. So that's the way we threaded that needle.
Thank you so much. I have a follow-up, but I see some gentlemen in the audience. So yes, sir.
Hello. Hi. John Tennyson, the New Season Treatment Center, San Antonio, Texas.
Thank you.
Hello again. I really appreciate your mentioning retention as a principle in harm reduction. I've been, as a physician in program, methadone, OTP programs, and buprenorphine programs too, I've been treating patients for about 25 years, and recently I've seen some thinking process that seems to assume that if someone has a resolved opioid use that's being treated, in which they're stable on methadone or buprenorphine with no cravings or side effects or sedation, there's something that I've seen it's new, maybe the last few years, where some people in programs have assumed that if they're not also abstinent from other substances, that it's a treatment failure and that they need to be kicked out. But so the question is, if someone is stable on methadone or buprenorphine, seemingly having reduced the harm associated with opioid use, but if at the same time they willfully continue the use of other illicit substances, should that person be kicked out of a program? My traditional sense was they should not, because we're still having some harm reduction for the opioid use. But I'm wondering what your thoughts are, if there's any body of evidence or even a show of hands of who might think they should or shouldn't be kicked out.
Got it. Thank you.
Yeah, I appreciate that question a lot. And when I talked about unlearning and really making sure it was grounded in the evidence, I know I keep citing papers here, I apologize. There was a paper by Stephen Martin et al., 2018, Annals of Internal Medicine, that really looks at some of these myths head on and says, well, wait a second here, should we be doing it this way? And how might we change it? And so I think there are two ways I would answer that question. The first is, no, they should not be kicked out. And really buprenorphine is treating the opioid use disorder. It's not treating stimulant use disorder. I wish, believe me, I wish we had a medication as effective for stimulant use disorder as we do for opioid use disorder. We do not. We have some things, and certainly contingency management, we can talk more about that. And so that's one answer, right? So no, please don't kick folks out. The second is, I think this is where harm reduction just has so much to teach us. It has so much to teach us about what good looks like. What does good look like? I mean, extraordinary look like, right? I'm here, we're talking about MOUD, great, absolutely, 100%. How do we make sure that whatever we're delivering, the care we're delivering, is centered in individuals' values, in their autonomy, and really making sure that we're designing and caring for people. And I think that's where principles from harm reduction have been it's been a welcome change I've seen over recent years, where harm reduction has been more and more integrated, not perfect, but more and more integrated into the way we deliver care more broadly. Thank you.
Thank you.
I'd like to kind of pop in with an online question real quick. And I'll note, Whova questions, they might come from the online audience, they might come from those in the crowd who'd prefer to submit through there rather than walk up to a mic, so feel comfortable to do either. But we got a couple versions of the same question, which is, we are really appreciative of the evidence showing the positive impact of Medicaid expansion in Virginia. And we do have certainly some folks in our audience who are part of their role is communicating evidence or engaging in advocacy for policy change. But a lot of us are just on the ground dealing with the realities of our non-expansion status. And so in that reality, what would you recommend as maybe other levers that can be pulled or specific approaches that could be utilized to fund and expand the quality and the availability of treatment for people who fall in that gap?
Thanks, Lucas.
Yeah, I appreciate that question so much. I think for each and every one of us in this room, there is where we have control, and then there is where we don't. There is where we can act directly, and where we maybe can act indirectly. And so I would say on the where we have control side, you can do what you can, whatever role you have, however you come to this, as someone with lived experience, as someone who works within a health system, as a physician, as a nurse, as a social worker, however you come, as a policymaker, however you come to this, you have a role to play in the space you're in by really holding up the evidence that we know around the importance of initiation and retention, really pushing back on some of the myths and the prevailing dogmas that conflict with the evidence, really looking at and understanding how might we better care for those who are most marginalized, even within this group of individuals with substance use and opioid use disorder. So that's sort of one big thing, right? That's a big thing. That's not a small thing. So if you can do that, great. I think the second thing we can do is we can, as a community, as a group, start to, one, articulate our values. Articulate our values. What is our value? Our value is around human life. It's around humanity. It's around dignity. It's around seeing people. That's why this science matters. It matters because it allows us to get closer to our values and beliefs, right? It allows us to do that. And so I think being able to articulate that through narrative, through data, and yes, that requires many of us to be uncomfortable and enter into spaces we're not used to say, why does it matter, right? Is it the Medicaid expansion, is that the thing that matters? Let's be real, it's about people having access to care. 6 in 10 of those who are uninsured go without needed care. And so if there are better alternatives, absolutely, to making sure that people have access to care. But that problem needs to be solved is not something we can wait for or ignore, hide our, just like stick our heads in the sand. We actually have to address it meaningfully. And I know everyone here really understands that and sees that. And so to the extent that we as a community can really help all of us, right, at the local level to state and the federal level, align our values with our action, I think that is absolutely necessary in this work to start to create the change that we all want to see.
Thank you. I can see you, but I'm a little blinded, so go ahead with your question.
Hello, my name is Ralph Luckner. I'm a internal medicine doctor who does OBOT in the Texas Panhandle. And I went to Baylor College of Medicine.
Right.
We talked a little bit beforehand. I was very impressed by what Harris Health is doing. I guess Houston has this hospital district that sort of fills the gap in terms of people who don't qualify for Medicaid, need treatment. The hospital district offers kind of an insurance. And it sounds like they have their clinics available in buprenorphine treatment, and many of the things that you talked about with the Medicaid expansion. Could you comment on what the Harris County Hospital District has done that's similar to this Medicaid expansion, and maybe this can be done in other places in Texas? Because I wouldn't hold my breath waiting for Texas to change its politics.
Yeah.
Thank you.
Yeah, I appreciate that a lot, and good to see you again, Ralph. He's a former alum of Ben Taub and Baylor. And so, yeah, I guess a couple things, and let me just be clear on the other answer that I gave. Expanding Medicaid has made a difference in the 40 states that it's been expanded. It will make a difference here that's very positive, just to be very clear. In the absence of the ability to expand Medicaid, what can we do today, right? What can we do today? And I think I am lucky my day job is at Harris Health System, which is the safety net system for Harris County in Houston. And so in that system, we provide care. 50% of our patients are uninsured. So we provide care regardless of ability to pay. So I'm fortunate in that way. I think those of us who are lucky enough to have something like that, a county-funded hospital district, have similar setups, right? This is San Antonio, Austin, Dallas, and so there are a number of other, El Paso, to name a few. And in those instances, those entities, I believe, can and to some large degree are leading the way. At Harris Health, and we have some wonderful folks from Harris Health here. I'm not going to ask you to stand up, but they are wonderful and they are here, who are doing work to really address that call to action, which is we have substance use disorder in our community. We have individuals who don't have access to care. What difference can we make? Whether that's really thinking about what we can do in the emergency department, a bridge clinic, same day initiation, whether that's in the ED or inpatient side, expert in those acute care settings, office-based addiction treatment, and how do we improve that and expand that across our system. And so we're really thinking diligently about how do we start to knit these together so that we can improve the experience of care for patients, understanding that that experience means that people will remain and stay in care. And so I hope that's started to answer some of your question.
Yes, that really does answer the question. I think it's really impressive what Harris Health is doing, and I look forward to maybe having similar programs in other places. I'm in a rural area, so I don't see a hospital district coming anytime soon, but something like that would be very helpful.
So I will just intersect for 1 second because I've got colleagues here from the Texas Targeted Opioid Response, and I will say in Texas right now we have universal access to office-based addiction treatment. And if you're not familiar with that program, in addition to the many programs in the state of Texas, you should shop by the Be Well table because I do have capacity for telehealth throughout the state unfunded. So it certainly might not be sufficient, and there's certainly opportunities, but there have been activities, and many of you in this room have been a part of building that capacity. And I think it's a great example of how we work within the systems that we have. So I applaud you at Harris Health as well. Van, Dr. King.
My name's Van King. I'm the medical director of Be Well, Texas at UT Health San Antonio. Thanks for a very nice, concise talk. It was very educational. I just wanted, because I realize we have a lot of psychosocial providers here in the audience, and I really think that for many of these patients with very serious substance use problems, medications can be essential. But without that psychosocial component and helping that person sort of reimagine themselves in their recovery, that's why many people drop out of their medication-assisted treatment, right? Because they're continuing to use other drugs. They have some harm reduction. It's not enough to keep them sort of moving forward in their lives. So I just wanted to shout out to my psychosocial colleagues. Very, very important part of probably essential for many people.
Yeah, thank you for that. I think that's such an important part to play, and I love the way you framed it, right? Which is the goal is not to meet some standard that's up here. That's our standard. It's to really meet people where they are. And individuals are, who provide behavioral treatment can help do that. And to the extent that we're doing that and thinking about how can we be as person-centered as possible, it really can and does make a huge difference. So thank you.
Thank you. I'm going to go one of mine, and then I'm going to come to you just 1 second. So We were talking about detox, and there's a session that we have at the conference on de-implementation, and this idea of unpacking programs that do seem to have a lack of evidence. And so I'm wondering what you think about de-implementation. How do you respectfully understand the context of programs that have been in existence for a very long time, that do good work, that believe in what they're doing, that care about it? But how do we also balance that with what the evidence is showing us over time? Because the knowledge is accelerating so quickly now. How do we deal with that collision there?
Yeah, the realities of that. So I appreciate that. That's great that you have a session on de-implementation. I would argue that in general, just from a behavioral science perspective, it is easier. I'm not saying it's easy. It's easier to stop something than to start something. And that's sort of a general principle. But how do you do that in practice when so many folks have been trained in, have done this work for decades, and have done it with the right intention? How do you do that? And so that's something I experienced in Virginia. And the first thing I'll say is that I don't know if it would have been possible without such clear data. And so, maybe my first sort of response to that is the more data we can have about, what's going on in our communities, what's happening in Texas, the better. The easier it is to start to understand, what the challenges are and how we're tracking against them. So data is really important. In the study I mentioned in Massachusetts, the only reason that was possible was literally an act of their legislature. And they signed a law in 2015 that said, the overdose crisis is a threat. We're going to connect all the data sets so you can see this clearly. And I'm the beneficiary, and I hope you are as well, of that insight and that data to say. And so it started with that. And so I mentioned as part of my talk that we went around the state multiple times, speaking with clinicians, sharing that data to say, what do you make of this? How do you understand it in your practice? And when I think you can center people's values, like they're in it for the right reasons, and be able to share data and bring them in. And they said, well, actually, no one from the Medicaid program has ever come to us and asked us. And so that, too, was a lot about building trust with those individuals. Some of those, and then we said, well, based on our understanding, at the time, we had this lever of authority to say, we're not going to pay for it. And so that's what we're thinking about. What are your thoughts? And they're like, well, that's not great, but we understand. Can we work with you on this? And we worked with them. And some people stayed within the program, and some didn't. And so you may not convince everyone, but I think the process, trying to really center people's humanity, right? Like we don't just leave our principles at the door when we're trying to get change done. The same principles we bring into the patient room, we bring into every other room, the conference room as well. And so I think recognizing that yes, we are data-driven, but we're doing this so that we can, respect, dignity of each individual and really improve people's lives. That's why we're trying to do this work. And so that's how we did it. Mm-hmm. It was a lot of effort to do that, but I think it was meaningful. I mentioned we had 230 sessions, or more than that, sessions, many of them were on WebEx and Zoom, to really start to share the emerging evidence. So it was a lot of communicating about what's changing, how is it changing, how do you understand it in discussions. And over time, we were really able to make some, I think, important strides and changes. More work to do, but I do think it requires really bringing people in, whether you agree with them or not, especially initially.
The other thing I just want to amplify is a point you made earlier. I think I heard you also say that it's not abandoning everything. It's not that everything is wrong when we're doing this. It's how we reconcile the pieces that are so good in programs, and reconcile that with the data to see what types of changes we can make. Is that what
Yeah,
I
no,
heard you say?
that's exactly right. And that's where quite frankly, the dialogue is so helpful, is to really get at the details of like, well, what are we trying to do here, right? And what do you think about this data, and where can we start to really integrate these insights so that you yourself are more aligned and your program is more aligned with your own set of beliefs.
Great, thank you so much. You, sir.
My name's Curtis Bone.
Oh, I know you, sir.
It's hard to
I just can't see you, sorry.
I'm an addiction medicine physician at UT Health in Be-Well, Texas. I really appreciate the talk and really appreciate that slide where you highlight vulnerable populations and one of those people recently incarcerated, you mentioned, have 30-fold increased mortality within those first 2 weeks after leaving a jail or prison, and that's a system that, forced detox has been the approach to care there, unfortunately. A lot of those systems are really closed off, and you showed some really impressive benefits to providing linkage to care in the ED, and I was just curious if you could share a little bit about approaches that you're aware of across the state or within Harris Health to address the needs of that very high-risk population, and just curious what traction you may be finding successes and also how you might be approaching any challenges for treatment integration there.
Yes, so first of all, thank you for that question. It's also been on my mind as of late. When I think about the type of system we need, it's a system where there's no wrong door. This low threshold, high retention approach to care, and that means using every piece of data and knowledge we have and putting that into action. And so, yes, the ED is an ideal opportunity. And we're doing that work in Harris Health, and I would encourage every single person here who has an interaction with the ED or hospital to try to do that work. But let's not forget our criminal justice system, right? The war on drugs, this is like, you could have a whole conference just on the war on drugs and the damage it's done to communities, low-income communities, communities of color, and we have the highest incarceration rate in the world. By far, 5, 6, 7 times higher than the United Kingdom, Germany, right? Canada, some of these countries that we consider in some ways our peers. 5, 6, 7 times, that is unbelievable. And we don't offer them quality care. So what are we doing, right? I think that's let me just say that. Let's just start there. What are we doing? And when folks leave, we're contributing to overdose risk and overdose death. We are, that's a fact, and I wish it weren't. And so maybe I'll just say a couple more things. The first is that we know a majority of individuals in jails in particular and in prisons. And jails, I think, are, yes, let's pay attention to prisons, tend to be state controlled. Jails are really important. They're county control for the most part. And that's where the majority of people are coming through, right? And they are the major contributors to the risk, just from a volume perspective. Majority of folks have a substance use disorder. Estimates are around 15% of those in jails have an opioid use disorder. But maybe 10, 20% of jails are offering medications for opioid use disorder, and fewer are doing systematic screening, and that's a problem. And I would say that when we do offer care in the jails, particularly for opioid use disorder, it makes such a huge difference. So in the state of Rhode Island, small state, unified prison and jail system, they took this on. In 2016, they said, we're going to systematically screen individuals with opioid use disorder, and we're going to offer all 3 forms of FDA-approved medication for opioid use disorder: methadone, buprenorphine, naltrexone. 60% of folks chose methadone, 39% buprenorphine, 1% naltrexone. A lot of that had to do with what people were used to and what they had heard about and what they thought maybe worked for them in the past. And they formed close relationships with outpatient addiction treatment providers in the state, and so had warm handoffs. And what they found was within a very short period of time, they reduced overdose deaths among that population by 60%. Through that one intervention, 60%. And I think important for the broader context of the overdose crisis. While other states in the region, think Massachusetts, for example, were experiencing increases in overdose deaths, Rhode Island was the only state to experience a decrease in overdose deaths, statewide, of 12%, because of the huge proportion of individuals who were coming, who were overdosing and coming from incarceration. And so with that type of evidence, with that type of real-world evidence of what's possible, how might we really encourage and increase access to care within jails? And I think this is where your voice really matters. Your voice really matters. If you work in a jail, please help. But even if you don't, really calling this out as we have a responsibility, right? We have a constitutional responsibility actually to provide care in the jails and in the prisons. And so why aren't we meeting that mark, and how might we do better? If we're really serious about addressing the overdose crisis, we'll make sure that every single jail, every single prison in this country is systematically screening and treating for opioid use disorder and warm handouts, and even better, we'll make sure fewer people are incarcerated related to substance use disorders, and treatment is really handy and available. And that's work that I'll just say locally, and shout out to some of my colleagues in the audience who are doing this work, who are doing the outreach to drug courts in Harris County and judges to start to change attitude and understanding and education person by person, judge by judge, court by court. We now are forming connections with our Harris County Jail and also are doing better about treating or at least continuing folks on MLUD. We have more work to do, absolutely, but we're starting and we're taking those really important, sometimes very difficult steps to make sure that we're delivering standard and in that way addressing the overdose crisis.
Thank you, Dr. Bachireddy. Dr. Dethian, he's going to go to an emergency medicine expert here, right?
Okay, great.
Perfect segue for you, Dr. Dethian at JPS.
Well, that's what I was thinking. I stepped up at the right point. I'm Jim Dethian. I'm an emergency physician at JPS Health Network in Fort Worth, Texas, and with integrative emergency services across the state. So my question to you and everybody in the audience, since we have lots of communities representative, is what can we do? You gave a really great talk about the bridge process, right?
Yeah.
What can we do in each of our communities to bring about the reality of Texas Bridge 2024?
Yeah, I love that question. Let me just clap for that question. See, I knew I was in the right place. I knew you guys, oh man, this is great. So what can we do today? Well, I think it first comes with an understanding of the opportunity and the missed opportunity to really meet people where they are and reduce overdose risk and overdose death. In the emergency department, in the inpatient setting, for us in Virginia, it was about changing our sense of what was the standard of care. The standard of care is a bridge clinic. It's offering individuals access to evidence-based treatment, particularly when they're in crisis, and a warm hand up. That's the standard of care. That's not doing extra. That's what we are there for. And so changing that understanding, I think, is really important. You know, there are a couple of states that have done this. California did this. And I didn't want to bring up California here, but California did this. And they did this across hundreds of hospitals through a very intentional program that started off as a voluntary program. In Virginia, you know, I left about a little over a year ago. We started, you know, there were already 3 bridge clinics. The 15 that we expanded to, they raised their hands. They said, we want to do this. We've just been looking for the kind of right resources and support to figure out how to do it. And so we had some funding in terms of grant dollars, and we had, you know, experts who were willing to, you know, really coach systems throughout this and really kind of share this with their CEOs and other folks. And so I know it's eminently possible. My understanding is there are even nascent efforts here in Texas.
Over 3, I think there are 4 or 5 bridge clinics in Texas.
So there are efforts here in Texas that we can learn from, right? These exemplars who can teach us, all of us. And, you know, I don't know if any of those folks on the audience, but can we just give you some money so you can help really spread? Can we give you some money so we can?
We have a bridge clinic. We take your money. Would you like to give us some money?
Yes, fantastic. You guys can take this
I know Fort Worth
nifty
would be
microphone.
happy to get it from Harris.
And really, you know, really stand up these exemplars to show it is possible in this state, and the outcomes it makes are really tremendous. And I have no doubt that you will get an enormous response from health systems that they're like, wow, this is something we want to do.
So I think we might have our next TxSUS session. That's a plug for our webinar series throughout the year. Maybe we could have Dr. Dethian and you on, and we could be doing some primers on bridge clinics. I know that Dr. King would be happy to do that as well. Lucas, I think you have a final question from the online audience.
Yes, yeah, based on our timing, this will be our last question, so thank you to all who submitted and have been stepping up to the mic. Let me preface this by saying that it comes from a physician friend, Dr. Weems, in the audience. He says, behavior change is hard, and doctors are the worst. In addition to policy incentives, are you able to share any insights on how so many prescribers changed their behavior to take on bupe prescribing in Virginia?
Yeah.
And let me add a modifier and just ask if you have a sense of how many were in primary care specialties, which we think of a lot, versus were there some non-addiction medicine specialists stepping in, infectious disease trained folks like yourself, cardiology, et cetera?
Yeah, so thank you, Dr. Weems. Sometimes doctors are the worst. But Dr. Weems is great. Dr. Weems is around here, he's great. And so I think, and I think what Dr. Weems is getting at is, how can physicians lead this? There was a national survey among primary care docs, and I don't like this, but basically about a third of those primary care docs did not think that medications were one of the more effective treatments for opioid use disorder. That was a pretty recent survey. And only 20% of those in primary care were willing to care for those with opioid use disorder. That's a problem. And that's a problem in terms of how we're training docs, how we're teaching them about what it means not just to be a medical scientist technician, but what it means to heal, what it means to care. And so that is a challenge within the system of training. I was lucky in that I got to see, even as a medical student, what it meant, what good addiction care meant. And so that formed, that's probably why I'm here today in some regards. But most medical students and trainees don't get that. Now, I've seen positive changes over time, and I've seen addiction and substance use disorder, addiction medicine, become actually a place where clinicians from different specialties, OB and cardiology, anesthesia, internal medicine, family medicine, come together and start to share a different way we could be delivering care. And so I'm going to get a little grandiose here, but I believe that if we continue on that positive path, addiction and care for those with substance use disorders should start and could start to be the gold standard for how every single person, whether they have substance use disorder or not, should be cared for in this country. I think that's possible, but it's only possible if we start to change the way we're training physicians, teaching them and sharing with them so that we can destigmatize this condition and save lives.
Thank you.
Thank you.
Well, I'm sure we'll extend that to our advanced practice professionals that
Yes,
are big
yeah.
parts of this as well. So I just can't thank you enough so much. Lufkin, Texas, is that right?
Lufkin, Texas, yeah. Born
So
and
we're
raised.
very glad to have you back in Texas, and look forward to seeing all what you're doing and joining us again in the future. Please give your thanks to Dr. Bachireddy.
Thank you so much for the great discussion. Appreciate it.